Good afternoon, everyone, and welcome to today's RDLS session. Today's speaker is Dr. Kamlesh Upadhyay, and he is the professor and head Department of Medicine and Program Director, Center of Excellence in HIV Care at BJMC Civil Hospital, Ahmedabad. He has actively contributed in developing treatment protocols for diseases like COVID-19, mucormycosis, CCHFV, leptospirosis, etc. He has more than 35 noteworthy papers published in national and international journals. We welcome you, sir, for the today's session. I'll need to start the session now.
जी नमस्कार। नए संसद भवन के साथ पूरे देश में एक ऊर्जा की लहर है। आत्मनिर्भर भारत की बातें पूरे विश्व को सुनने को आने वाली है। आज मेरा टॉपिक है पैलिएटिव केयर फॉर द एडल्ट्स एंड चिल्ड्रंस विद HIV। This session will discuss about the palliative care in HIV, management of the pain, end of life care, palliative care in children, and home-based care. What is palliative care? Active total care of the patients whose disease is not responsive to curative treatment is a palliative care. It is an approach that improves the quality of life of a patient and their families facing the problems associated with life-threatening illnesses through the prevention and relief of suffering by means of early identification and impassable assessment, treatment of pain and other problems, physical, psychological, psychosocial, and spiritual. Palliative care extends, if necessary, to support the bereavement. As we can see in the graph, as the natural history of HIV progressed to AIDS, from diagnosis to death, the curative care will be very minimal and palliative care requirement will be more. And even after the death of the patient, for the caregivers, for family, the care we have to continue, because it is not a disease of only individual patients, it's a disease of the family. Those who are caregivers, they are also involved closely with the patient management. Palliative care in HIV, it should be family and patient centered. So it's not a disease of only patient, it's a family. Whole family is suffering, from income to nutrition to expenditure, everything. Optimize the quality of life by active participation, prevention and treatment of suffering. Involve an interdisciplinary team approach throughout the continuum of illness, placing critical importance on the building of respectful and trusting relationship. Address physical, intellectual, emotional, social, and spiritual needs. If you look at the components of the palliative care, pain management, symptomatic treatment of the disease, nutritional support, psychological support, spiritual support, and end-of-life care and bereavement counseling for the relatives and the caregivers. Pain management, first step, we have to first assess the severity of the pain and what is the site of the pain and the nature of the pain. If there is infection, prompt management of the infections with antibiotics. The severity of the pain should be graded. PQRST. P is a palliative factor or provocative factors. What makes the pain better? What makes the pain worse? So just deglutition of the food that increases the pain. Oh, this may be odynophagia due to glossopharyngeal movement, or it may be some local compressions, lymphadenopathy compressing mechanical compressions. Quality, Q for quality, what exactly it is like. What is the character of the pain? Burning pain, sharp shooting pain, the catch in breath, on deep breathing, oh, that is catch in breath, or persistent boring pain, his mind focus over there, continuous pain is there. Reduction of the pain. The pain in the gallbladder may relate to the shoulder. So, reduction of the pain. The cardiac outer side of the left arm and forearm. That is addition. Severity of the pain. How severe it is? Does it affect your life or not? And T for temporal factors. Is it there all the time or does it occur come and go, come and go? Is it worse at any particular time of the day or night? What we say is a circadian rhythm of the body. The same way, the pain may be present at certain, after taking rest in a supine position, the one can have a pain, or while changing the position, or sitting up from supine position. We have to judge the severity of the pain. It can be descriptive scale. It is just a 20% or 30% improvement after medication. Numerical scale, visual analog scale, percentile scale, coin scale. I'm feeling better than yesterday. 50% is better. No, it has become worse after your treatment. It was yesterday around 20-30%. Now it's 75%. In village, sometimes Athani, Barani, Gujarati, the common words will be used. And a face scale. By when patient is not comfortable, you can see the facial expressions can have. And that's why I ask them to quantify. That will help in whether your psychological counseling, your pain management, drugs are effective or not, drugs requires increase in dose or not. So every time you meet the patient, we have to grade the severity from 0 to 5 fingers. And you can draw the smiley also accordingly. It's a visual analog scale. 1 finger, 2 finger, 3 finger, 4 finger, 5 finger. According to severity of the pain. To decide treatment strategies for the pain, we have to keep certain principles in mind. As far as possible, give the oral medicines rather than rectal suppository or intramuscular injections. Give it at a fixed time interval, even if there is as per the half-life of the medicines. Start with small dose, tighter dose as per the improvement of the patient's or deterioration or no improvement. The overlapping of the drugs should be there. So before the second tablet's effects, before the effect of the first tablet decreases, wears off, you give the second tablet so that the sustained level of pain is sublimized. And in between, if required, extra rescue dose of the drugs may be given to the patient. Step 3, prescribe analgesics, use of opioid and non-opioid medicines. Give only one drug from opioid and non-opioid groups at a time. The exception is if codeine cannot be given, use aspirin every 4 hourly combined with paracetamol 4 hourly. The codeine is known to produce constipation, severe constipations. And that staining tool may precipitate myocardial infarction also. So whenever you give codeine, give laxative. That is to be kept in mind. Aspirin, paracetamol, you give it every 2 hours so that there is overlap of the effect and patient will be pain-free. Pharmacotherapy must be as per individual patients, his improvement. So first of all, judge the severity. Pain is mild, moderate, or severe. For the mild, aspirin, paracetamol, NSAIDs, plus some adjuvants. And for moderate pain, the opioids, codeine, hydrocodone, oxycodone, and so on. And for severe pain, morphine, hydromorphine, methadone, and so on. Fentanyl injections is commonly used. Fentanyl patch are also coming from sub-Q absorption. They are available. So it should be in the gradually increasing dose, decreasing the duration by mouth preferably. Second is a suppository, and injection requires special care. So it should be at the last resort. So in WHO, analysis letter is like non-opioid plus adjuvant, pain increasing or persistent. Then step 2, add weak opioids for mild to moderate pain. Non-opioid plus minus adjuvants. If there is still no relief, strong opioids for moderate to severe pain. Once there is a freedom from pain, maintain that dose of the medicines, and then gradually again revert back to non-opioids. Various paracetamol and NSAIDs drugs are there. We know paracetamol, aspirin, brufen, diclofenac, naproxen, piroxicam, ketoprofen, ketorolac, all doses are there. The opioids, which are used mainly for the cancer patients, codeine phosphate, hydrocodone, oxycodone, and tramadol. I'm not going in individual doses. The commonly used opioids for the cancer patients are morphine immediate release, morphine controlled release, and morphine sustained release. Morphine suppositories, same way for oxycodone, immediate release and controlled release, and then fentanyl, transdermal pads, and so on. NSAIDs acting on the inhibiting the cyclooxygenase pathway. Recent NSAID therapy includes COX-1 and a COX-2 inhibitor. Ketorolac is also available as an oral intramuscular and IV formulations. The choice of NSAIDs must be individualized as per the patient's need. Common side effects of NSAIDs are periorbital edema and GI intolerance in the form of a burning pain, nausea, vomiting, and sometimes it may manifest as a melena, black color stool. Particularly in elderly people, there may be a life-threatening bleeding also is possible. Those who are in A or O blood group, they have a risk of gastritis small. The opioids, opioids are basically essential components of a pharmacological management of the pain. It can be classified as weak or strong, depending on the relative efficacy in a releasing pain. Morphine sulfate is a prototype opioid agonist and is designed by WHO as a drug of choice for treatment of severe pain associated with the cancer. The half-life of the morphine is approximately 2 hours, and it is available both as an oral, immediate release, or slow release preparations, sustained release preparations that permits once or twice daily drug resign therapy. Oral administration of the opioid is convenient, well-tolerated, inexpensive, and effective therapy. Most common adverse effect of the opioids is constipations, nausea, vomiting. Non-pharmacological therapies is of utmost importance. Aankh mein ami, haath mein hit. Just talking to the patients, just say hello to the patients, eye-to-eye contacts. He should realize that my doctor is taking, or my counselor is taking interest in me. He is listening my problems, even if they are silly ones. Give attentive to the symptoms of the patient, and that rapport will have a better healing as far as pain also is concerned. Once you are talking to the patients, that also diverts the mind of the patients and he will relax. So hypnosis, music therapy, specialized cognitive behavioral interventions, massage to the affected portion, wherever he is complaining pain, have a touch. That touch also makes lots of difference. Then there can be a heat pad, or when there is acute trauma, you can apply the ice. For the chronic, you can apply the heat also. Or there are electric stimulations, sort of diathermy and other physiotherapy people are using. That sort of a stimulation is also one of the mode of treatment for the pain. Patient pain problems, for burning pain, abnormal sensations of the pain, severe shooting pain with relatively little pain in between, episodes of pain, pin and pricks needles. Basically, pregabalins are used. Amitriptyline can also be used for such patients. For muscle spasm in the end of life care, particularly when there is a spasticity in the limbs and flexor spasms are occurring in the muscles, thigh muscles, calf muscles, diazepam, orally or rectally. Herpes zoster, before the skin lesion appears, patient will feel even a movement of hair, or just I cannot wear the shirt because just touching of the shirt will develop pain. You examine, you will say, oh, it's a psycho. No, on third or fourth day, the small vesicles may appear. So remember this herpes zoster, before the vesicle comes, even a touch of the wind or touch of the shirt, clothes will produce pain. And it should not be neglected. Amitriptyline will be better, acyclovir, if the herpes zoster vesicles are erupting, then acyclovir. Locally, gentium borate can be used for the ruptured vesicles. GI pain. GI is a hollow structures. Whenever there is a hollow, it may be ureter, it may be intestine. Wherever there is a hollow structures, there will be colicky pain. And the symptoms from vomiting, diarrhea, constipation, abdominal fullness, gas passing, visible movement of the intestines can be seen on the abdominal examinations. If you power spirit on the abdomen, that will stimulate the movement of the gut, and that will produce a visible peristalsis. You power the spirit on the abdomen, and that will stimulate. You can make it prominent. So codeine can be used, and hyoscine, which are the antispasmodic agents, they can be used. Again, if the constipation is there, keep that thing in mind. That drug is going to add the constipation. For a bone pain or renal colic, dysmenorrhea, ibuprofen. The pain from the swelling around the tumor, severe esophageal ulceration and cannot swallow the food, severe mouth ulcers, severe esophageal ulcers, they cannot swallow the food properly. The radicular pain, when the nerve roots are coming out of the intervertebral foramina, and that is mechanically compressed, either because of the disease there, tubercular spine, or even in normal people also, obese people, the tummy is out, they will have a radicular pain. Severe headache, persistent severe headache is a sign of raised intracranial tensions, where tuberculous meningitis and other intracranial space occupying lesions are most common cause of raised ICT. Many times it's a part of end of life care, and referral is not desired in this. When you know that this is a diagnosis, and now in spite of opioids, everything, patient is not improving, steroids may be considered under the careful clinical supervision. If TBM is suspected and some meningeal irritations, then imaging, referral with imaging may help. But before shifting of the patient also, give a steroid and then set the patient, so that whatever the travel time is that part will be taken care. The other methods, additional method of pain control, emotional support. The mother who's a mother having history of dysmenorrhea, the daughter will also have a history of dysmenorrhea. because he has seen the painful days of the mother. So he'll also imbibe the same behavior. Emotional support is important thing. Whenever the pain is there, you have a touch with try the local methods, local pressures, warmth. Your touch will have a warmth. And the patient will feel that, oh, my caregiver, maybe relative or maybe a paid person, he has got a rapport with you and he is taking interest of my pain. So that emotional support, it will be all right, huh? Don't worry. I'll just bring the water or a glass of milk and it'll be all right. That eye-to-eye contact plus conversations with the patient will make it very easy. Medicine with psychological support, medicine without psychological support. And you see the difference. If the child is small, cannot speak, and then just burping or rocking or just giving vibrations, that will relieve the pain. Sometimes, as I told you, ice for acute trauma, ice, and for chronic pain, heat. The hot water bags are there, electric pads are coming, sort of diathermy, up to that level. Cognitive methods, distractions, to divert the mind of the people. The radio, dance, music, or किसी और बातों में बच्चा है उसको बातें कीजिए. Once you talk about various stories, it will take the child in the different world of imaginations, and that will relieve the pain. That will divert the mind of the patient. And of course, prayers. A traditional practice that are helpful is not harmful. The prayers will improve the concentrations. And the faith in God has a faith is a best healing factor. Prayers should be advised. Symptoms, prayer not only alone. Whole family will pray together, and that will have a different vibration system. A management of symptoms with the medications, nausea, vomiting, give Domstal. Perinom has got some Kalimata syndrome, like so we avoid because it's got extrapyramidal side effects. So we prefer domperidone or ondansetron is given orally or intramuscularly. Those are in nausea and vomiting. Ask them to take a frequent meal and small eating to avoid empty stomach, as this makes the nausea worse. Those who are having jaundice, they have more conditions, more problem because the whole stomach is congested. Ask them to eat a bland food, not too spicy, not too much. The odor should be unpleasant, odors should not be there. Drink plenty of liquids, rest, relaxation in between meals. Have a sitting up posture in between the meals. Avoid coffee, alcohol, smoking, etc. And if there is a signs of dehydration, that is a shrunken eyes, the voice is small, and it is you have to make effort to listen. Then if you look at a tissue target, when we touch the skin and release, it completely becomes normal. But if there is a delay in after pinching the skin, if there is delay, tissue target is lost, then it's a sign of dehydrations. Mouth ulcers and pain while swallowing, it can be a simple deglutition problem or dysphagia, or it may be odinophobia, painful swallowing. Ninth nerve, when is involved in the deglutition is painful. In herpes of the ninth, it's a painful deglutition. And other fungal infections like candida, some ulcers in the mouth, abscess ulcers are there. If the white coating is there, candida is suspected. Then oral fluconazole is a treatment of choice. Topical anesthetic agents, Xylocaine viscous, xylocaine jelly, gargling with that will relieve the pain in the mouth ulcers. Or otherwise, you can take oral analgesic also. For the abscess ulcer, the steroid tablet crushed and applied in some honey or something that can be applied on the ulcer. And Zyte and other low-cut liquids are available for the local mouth ulcers. For herpes simplex, some vesicular eruptions, nystatin solutions are available, metronidazole tablet, and acyclovir. And we have to combine and we can do a painting on the ulcer. Remove the food stocks after every eating. Clear the mouth properly. Have a proper mouthwash. And if the patient is ill, you can take the artery forceps. You can have with the cotton wool or gauze, a soft cloth. We have to remove the food stuck in the mouth. So mouth care with the artery forceps and gauze piece. The patient is cooperative, this is the mouth with diluted salt water. The mouth was with aspirin in water, 2 tablets of aspirin water. Soft diet will also relieve the discomfort. Instead of chapati, you give them the puris. Too much hot or too much cold food should be, and too much spicy also, should be avoided when there are mouth ulcers are there. Commonly used antiemetics, they are ondansetron group, metoclopramide, chlorpheniramine, haloperidol, dexamethasone, and lorazepam. The metoclopramide has got Kalimata syndrome, the pulling out of tongue, and he cannot open the muscle undergoes spasm, known as Kalimata syndrome. Generally, we avoid that medicine. For the hiccups, it's a quite common problem with the HIV patients. Then we should try with the, first of all, examine the local, any old thrush is there or any ulcers are there, you treat that. We can give the Domstal, haloperidol, and if the patient has got some intracranial lesions, tuberculoma or some cysticercosis, neurocysticercosis, some brain lesions are there, then patient may require anticonvulsants, antiepileptics therapy also. To bedside maneuvers, like to stop the hiccups, you stimulate the throat, at least ask him to swallow 2 teaspoonful sugar. Ask him to drink a cold water or eat crushed ice. To rub it with the clean clothes inside the top of the mouth. Interrupt the normal breathing by holding breath or breathe into paper bag. Ask him to pull out the tongue and maintain it. Or pull knees to the chest and lean forward. You pull knees to the chest and lean forward to compress the chest. There are some maneuvers which can help in relieving the hiccups. Bed sore, those who are bedridden, they are already having a loss of muscle mass, fat is not there, and the whole bones are, the weight of the patient or a person is passing through bony points, and it may be a shoulder blade, it may be occiput, it may be shoulder blade, it may be a sacroiliac area or sacral area, and it may be the backside of the heel. These are the area through which the body weight is transmitted on the bed. So that contact pressure and skin and other areas has a ischemic tolerance up to 45 minutes. So that's why the patient is remaining in a same position for more than 1 hour, 2 hours. The risk of bed sore is small. So turn the body every 2 hours. The patient cannot do it himself. So rotation of the patient every 2 hourly. There should be a dry skin so that the bed sheet should be a pure cotton one instead of terrycotton or polyester. It should not be there. Dry. It should be tight. The skin fold should not be there in between the fold of the bed sheet. Make it dry. Apply the take the dust and apply it on the back. Use the air bed or water bed. And these are the way. When you are using the water bed in the summer season, that because of atmospheric temperature, the water within the water bed temperature also rises. So as far as possible, go for the air beds rather than water beds. As far as treatment is concerned, for small sore can be preventable with the frequent change of posture, dryness of the skin, and air bed or some extra material. Again, I'm emphasizing on the cotton linens. The small sore can be cleaned with the salt water and allowed to dry. Apply honey on the bed sore that are not deep and leave the wound open on the superficial when subcu is seen. If painful, give painkillers such as paracetamol or once the cutaneous, when the sores become deep, so the nerves are dying, and that's why pain may not be there. So for deep or large sore, every day clean the bed sore with gentle diluted salt water and fill the area, bed sore area, with the pure honey and cover with a clean light dressing to encourage the healing. End of life care. How people die lives in the memory of those who left behind. A पीड़ा की moment होती है when we are living our near or dear. The terminal phase is defined as the period when day-to-day deterioration, particularly of strength, appetite, and awareness, is occurring. Is it difficult to predict when death will occur? And is it better not to do so? The aim of the care at this stage should be to ensure the patient's comfort holistically and peaceful, dignified death. We have to provide psychosocial and spiritual support. Other patients, active listening, counseling, and social and emotional support. Spiritual support is very important. Be prepared to discuss all matters if patient would like to, even about the death, about his fear of the children's, everything. We have to learn to listen with empathy, sympathy, and empathy. Sympathy is just your feelings to the patients, and empathy is putting yourself in the position of the patient and then to react. That is empathy. Samanubhuti bolte hain. Sahanubhuti nahi, samanubhuti. Put yourself in that position. So before advising anything, be careful. Understand the reactions to the losses in their life. Be prepared to absorb some reactions. Sometimes healthcare workers may not be taken his emotion, because for the healthcare worker, death may be a routine phenomenon. But for the patient and relative, it is not a day-to-day. So they may show angerness on your comment or your light approach. They may consider that your approach is very casual. He is dying and you are not taking any steps. So we have to control our emotions as a healthcare worker. Do not impose your own views about the patient. May have their own social belief, their religious belief is there. So we have to respect that. Whatever you do, many times patient cannot be survived, but you can take care of their emotions by listening with them, by respecting their beliefs. Among all the family members, find out the person who is taking utmost care, and you make him a leader. Help the family to come to terms with the fact that the patient is leaving them soon. Let family members to be around to see and talk to them. If the patient is going gradually down, his level of consciousness is going down, you call the relatives that when he is conscious, sit with them, listen him. Once he is unconscious, comatose, coming on very terminal state, he may not be able to speak anything. So give privacy to the relative and patient. Suppose those who are taking daily care, but new relative is coming, sister is coming, brother is coming from other city. You give them privacy. Let them to discuss if they want to convey something. So this is what is an art. You deal with the anxiety and fears very gently. End of life care issues. You have to prepare the relatives for the death by encouraging the communication with them. You explain them what's happening, how will his clinical condition is going down. Those are having a brain tumor cases or some PBME cases, the respiration may be altered, respiration, consciousness level, cardiac rhythm, and blood pressure. These are the 4 parameters, vital signs that will tell you how he is deteriorating or he is sucking. He is sinking down. Discuss the worry of the issue such as custodial children. What will happen to my children? And just sympathetic as a relative, I'll take care. My mama hu na, I'll take care. The 2 words will give lots of patience to the dying person. About the speech of the students, of the children, what they will eat, they realize their mistakes at the last moment, and they have a pain for their, they're angry on themselves also, that because of my behavior, my children have to suffer. And that emotions, at the time, we have to support you. Whatever happened, happened. Now don't worry, every child is a gift of God, and God will take care. And we are there to support. That's few words will definitely make the dying person at ease. That guilt and regret may be expressed in the last moment. Whenever usually the people want to die, इसको बोलते हैं ना, जीवन में से गांठें नहीं चाहिए. Oh, he want to untie the knots which has happened in the because of his behavior, and in that phase, he want to discuss. He want to open up everything with the family member. He want to confess his mistake also. Sometimes give privacy. Follow his wishes. Treatment is not important. Let his wife or his son or relative to sit with him, and what I want to convey about some debits, some money, some bank lockers, many issues we want to discuss. Approach the patient with compassion. Outside we did regularly with home-based care. Someone needs to hold hand, listen, and converse with the patient and family. This could be volunteer, NGO worker, outreach worker, counselor, or family doctor. The caring provides comfort and physical contact by touching, light touch, holding hands. This is what I'll do. Hathma head, akhma ami. Have a doctor should be in a fresh. He should have a eye-to-eye contact. And when the dying person is looking for the hope in your eyes, and that hope should be seen in your eyes. That's the skill of a doctor. That hope, that warmth, holding his head tight. You place the hand here, place the hand here, and he will feel comfort. For the comfort measures near the end of life, keep the clean body, viscera. Any secretions are there, it should be from the mouth, the throat. After convulsions, he may urinate, he may pass the stool also. So cleanliness is important. The lips are dry, you apply some moisture, some drops in the eyes. Patient, if the pain is much, agony is on the face, then pain relief. If you give opioids, patient may be under sedation. So the drowsiness also is there. Sometimes it gives a side effects in the form of some hallucinations and everything. They may find because of the disease itself or because of side effect of drugs, they may find bugs in the pores, what we say. Now, tactile hallucinations known as scientifically. Eating less is okay. Dying person may eat less, but see that hydration is ensured with the RT. Don't feed in a supine position. It should be the head up position, 20, 30, 40, 5 degree. Skin care, moisturizer, skin creams can be applied to avoid bed sores. And make sure that pain is very minimal or his patient is pain-free. Signs of immediate death, decreased social interaction, sleeps more, is confused, is comatose, there is a decrease in the food or a fluid, spontaneous intake, no hunger, he will not complain of the hunger or thirst. It reduces the urine volume will be reduced, bowel movement will be less, incontinence will be there, patient may have irregular breathing or a death threat, what we say. Gujarati mein bolte, gharadi bolte usko. Last death because of some breathing is not adequate or vital capacity also reduced, and that will have a death threats. Infrequent breathing, apnea in between, apneic phase, no ceases of the respiration in between. Circulatory changes, the cold climate skin will be there. The cyanosis, that will be a purple color extremities. Heart rate will fall down, and blood pressure first and then heart rate also. And signs of death are breathing stops completely. You keep the abdomen area open and look for the chest movement, look for the abdominal movement. So up to keep the close below nipple level and above umbilical, so that you can see abdomen and chest both. You can look at the pulse, you can auscultate the heartbeat. There is no response. Even if you shake the patient, there is no responsiveness. The eyes are fixed, there is no eyeball movement. And pupils are dilated, eyelids are open or closed. And skin tone will be changed from white to gray. Patient will look more pale. Palliative care in children.
जैसे तो हर एक सेशन का अलग ही बनता है, तो हम उसको कहीं पे अपने वन ड्राइव में रखते हैं कुछ ऐसे दिखाना, तो हमारा
pediatric palliative care, a specialized comprehensive care approach for those who are.
सेशंस किए हैं कितने.
Please ensure that your mic is off. Please speaking. Please take care.
एक एक्टिविटी हमने जो दी थी वो एसटी वाली एनडीएलएस सेशन डीएलएस यूज करी थी. तो जैसे एनडीएलएस को तो उसमें एक सेशन में एक लिंक आ गया.
मैम आई डोंट नो आपकी आवाज आती है, kindly mute your mic. Pediatric palliative care is a specialized comprehensive care approach for children living with the life-limiting and life-threatening illnesses. WHO definition. Appropriate for the children and family is, it is the active total care of the child's body, mind, spirit, and involves the giving support to the family. It begins when illness is diagnosed and continues regardless of whether a child received treatment directed at the disease. Health providers must evaluate and alleviate children's physical, psychological, and social distress. Effective palliative care requires a broad multidisciplinary approach that includes the family and makes use of available community resources. An integrated palliative care consists of outpatient, inpatient, hospice, and home care to maintain the continuum of services. The mutual trust, establishing a mutual trusting relationship between the child and the family with the clinical team, and depends on the factors unique to the children. Physical, emotional, and cognitive development influence all aspects of care, from understanding of disease, drug doses, of communication skills, and death. The parents might have lost the child might have lost the parent, one or two parents. He might be at what age? Because up to 5 years of age, the whole, if during that phase, if the child is emotionally disturbed, single parent is there, foods, insecurity, all these issues will affect the psychology of the child. Most children are cared for at home. If the parent, if still alive, is present, the family unit needs to be given support and be taught appropriate skill. Many times, when parents are not there and grandparents are there to take care, the grandparents may have their own physical problems, maybe cataract, they may not listen properly, they may not be able to take their care properly, and they have to take care of the grandchildren. So that all emotional plus their physical limitations may be an issue. To assess the symptoms in the children, healthcare providers must provide an environment where children do not fear repercussions from their honest expressions. Children must have confidence in the healthcare worker that uncle meri baat sunenge, ye baat hai. He'll listen, I like, he'll come, he listens. He is not angry on my whatever I say, he is listening. So that rapport with the child is the most important thing. I used to ask every time to all the people, if you remember, if you close your eye and remember your teachers, there may be 70, 80 teachers in your life, but you remember only one or two. Who are they? They listen. They smile at you. And that particularly primary teachers, secondary teachers, remember that. They are not any, I think, exercise that because they attend you, and that's here also. Any healthcare nurse or counselor or doctor, anybody who is attending the case should listen with a peaceful mind. So the trust, rapport has to be developed with the child. Palliative care team should provide support during the emergencies and health crisis and help in the challenges of the day-to-day living. Particularly fever and some convulsions, they are the cases where they require special attentions. Relief of the symptoms and pain management need to be continued, even when the option to stop ART may have to be considered. Prophylaxis against the opportunistic infections to be continued in the pediatric, because they sometimes ART may be stopped, but they may require risk still continue. Essential components of the palliative care of the children's: pain management, symptom management, and psychological and spiritual component. The reason for inadequate treatment of a pain is inability to express the pain due to their age, lack of verbal skills, or disabilities. Few healthcare professionals are trained and skilled at evaluating children's pain and suffering. Healthcare workers has to become mother, because mother can recognize the cry of the baby is because of the wet nappy or he is hungry. And that sort of emotions, we should have a rapport that we can identify the need of the child if he is not communicating or only communication is a cry. Majority of the health professionals lack competence in prescribed opioids in children. Fear of using opioids for pain management due to common belief that it will lead to addiction. Acknowledgement and support for spiritual pain and conflicts and their impact of culture and language is mostly ignored in the children. Correct use of analgesic medicines will relieve pain in most children. Non-pharmacological measures, age appropriate active distractions. बच्चे को एक्टिविटी में कहीं जुड़ो. It may be a dance, it may be a group song, it may be a storytelling. As per the age, if the small child is at 1 year, you can just showing him some red color object, he'll be distracted. Sometimes mothers, dupatta will also he recognize and he will feel homely. The smell of that cloth will also relieve his pain. So games, some conversation. Carrying an infant, provide warmth, breastfeeding and feeding, stalking, burping, rocking, massaging, just to have a movement in the heads of the children, that will give lots of relaxations. Environmental management, including play opportunity, music, scheduled medical and nursing intervention, and structured opportunities for sleep and rest. Nutritional supports, adequate hydrations, and electrolyte replacement is a key factors. Symptomatic management, as per the symptoms, diarrhea, vomiting, cough, anorexia, mouth ulcer, as per the, or sometimes breathlessness, convulsions, symptomatic treatment is utmost important in a pediatric also. Psychological and spiritual support, it needs to be managed because the family dynamics may be different. Who is grooming the child? Parents are there, not there, one parent, it is on maternal side, paternal side, grandparents are grooming, all these dynamics and other relatives approach, stigma to HIV will also reflected on their behavior with the child. And that's why stigma in the community or in the close relative also is a major factor why child is feeling depressed. And who will take care? When mother is dying, who will take care? That those who are adolescent children, though they have a hopelessness, and at that time, the simple jadu ki jappi, what we say, that will also make a lots of difference in the life of the child. Home-based care components are symptoms and pain management, hospital referral for routine visits and acute care, treatment support for adherence and side effects of the medicine management, nutritive support, emotional support, spiritual support, some religious organizations, regular meeting with the religious leaders and spiritual leaders, and we have to ensure that the people don't keep stigma with them and they accept as normal people. Social services, income generation, child support, food support, every monthly some rations to be provided, or as per his physical fitness, we can provide him some activities for the income generations. Future planning, as the disease advances, the parents are mainly worried of this future planning about the self and who will be guardian of my child. And that's a major worry in the mind of the parents particularly. End of life care, pain management, funerals, and grief support to the family. The caregivers to know basic knowledge of HIV, which are the potentially infectious material, the viral transmission possibility through various body fluids, the personal hygiene, hand wash, mask not at the time, but patient is having tuberculosis. At the time, coughing, you may have to protect yourself with the mask on the patient's face first and then your face. The dusting time, when you are doing dusting, the bats, everything, where the aerosols spread the infections. So at that time, you must have a mask as a caretaker. So hand wash, cough etiquettes, and mouth protections. airway protections, prevention of infection and injuries to themselves, management of the infection at home, just like common beds or dressings, or mouth ulcers and mouth hygiene. Some nutritive food, what is protein, what is a pulses and protein, sprouted protein versus sprouted pulses versus non-sprouted animal-based protein versus green pulses based protein. So some home remedies, available foods. The child in a terminal phase, when they cannot take food, you pour ghee or oil in every food so that it is a protein and sugar versus fat. The calories are more. So when the quantity is decreasing, you add more oil, frequent oil in the food so that at least his calories are maintained. Symptom management at home, caregiver should know about the fever, weight loss, nausea, vomiting, mouth ulcers, pain, swallowing, pain on deglutition, dry mouth, dry lips, constipation, incontinence of the urinary stools. Some common remedies for that. These are home-based care. For intervention, there should be a kit having a sterilized gauze plate, 1, 2, or 3-inch gauze rolls are there, clean cotton is there, soap is there, scissor is there, calamine lotion, bleaching powder, petroleum jelly. It's a home kit for the care of the home care of the patient. There can be a gentian palliative crystals or solutions, potassium permanganate, crystals or solutions, betadine ointment, rubber gloves, plastic bags, towels set to clean the towels or a clean cotton clothes. Challenges faced by the caregivers. Stress in the caregivers can be identified by surfacing emotional symptoms like crying, worry or anxiety, irritability, anger, feeling exhausted, and or lack of interest in their activity. They also get tired with the long-term treatment of the patients. Even if there are relatives, they lose interest. Their time is passed in the keeping care of this patient. Their daily vision is affected. Their job is lost. So all these things are, so when they are emotionally disturbed or when they lose the hope that in spite of my this much care, my patient, my relative, it may be a son, it may be a father, it may be a, my relative will die. And that in last moment, the caregivers require support, emotional support more. Because sometimes what to do? Suppose he'll die, what I'll do tomorrow? And that vacuum in the life after the death of the patients. So caregiver requires more emotional support in the terminal phases, in the last days, terminal phases, and post-death also, they require psychological support. To relieve the caregiver stress, encourage them to talk to the friends, relatives whom they trust, participate in activities outside the home, let them to walk, let them to go to a temple nearby. They can take help of the, if they like any in-between care, they can use their own way of joy, singing to dancing to a badminton to whatever way he feels relaxed, to talking to some peoples. Train them to become a peer educator with positive attitude and approach. Train more family members so that his load also reduces. Identify additional caregivers within the family to provide needed relief, rest for the outbound caregivers. As the time passes, the caregivers also lose their patience and they also burn off. And they require special care because they have taken care for so many months, years, and now if someone is not there, that the last care of the patients will be affected or suffered. Thank you very much for the patient's hearing. These are diseases where we have seen after HIV, in a COVID time, we have seen in every district, many children have lost their single or both the parents. Those who are Gujarati listening me, they must read the novel Angariyat. The mother who is remarrying after the death of the husband and child is going with the to the different father, and that is known as Angariyat. So when there is a remarriage, the husband's previous children will be well accepted by the new coming mother, but the mother coming with the child will not be accepted by a new husband. It's quite common problem. So in a COVID also, we have seen the middle-age group, people have died. So the grandparents are there, children are. And it's a social responsibility of each one of us, so that whenever the childhood is disturbed with insecurity, without love, without affection, without any family support, the potentiality of that child to become a criminal is, or engage in a criminal activity is more. And that's why either it is HIV or it is COVID, it's a responsibility of the society, their community, to take care of such children who have lost single or both parents. Thank you very much for the patience hearing. Let's perspire together for the healthy Bharat. And any questions are there, I'll welcome.
So participants are having any questions, they can unmute their microphone.
For the death, in the Indian philosophy, they say death is not the end of life. पुनरपि पुनरपि जननी जठरे शयन, दूसरी माँ की गोद में जाके सो जाना, उसको मृत्यु कहते हैं. Every religion has their own belief, and in Indian way of, we believe in a rebirth.
Participants are requested to please fill this feedback form displayed on the screen. Sir, with your permission, I think we can conclude the session now.
Thank you, sir.
Thank you, sir. And sorry for my microphone, which was on for a while during the session. Sorry for that.
It happens. कोई बातें नहीं करता, कोई बातें करना अच्छा लगता है.
Thank you.
Can I leave?